Good morning, everyone. My name is Dr. Franklin Orlando Ordoñez, resident of second year of radiology at Hospital Universitario, Monterrey, Nuevo León. Today, due the international quality program of CONACYT that certifies our resident program, the next lecture will be performed in English. So, welcome to our first class given in English. Today's theme is Congenital Variants and Anomaly of the Aorta. Advising teacher, Dr. Nestor Rangel. Okay, the congenital anomaly of the aorta are uncommon, may be associated with other congenital cardiovascular disease. Okay, they are asymptomatic, therefore they are incidental findings. To understand our theme, we have to know how the normal aorta is. Okay, the normal aorta has different segments. In this picture, they are represented as the ascending aorta, which include the aortic root, then the aortic arch, and then the descending aorta. Descending aorta are divided for the diagram, and thoracic aorta and abdominal aorta. The abdominal aorta has suprarenal and infrarenal division made from the renal arteries. Okay, and before we start talking about congenital anomaly of the aorta, we have to remember the embryology. Okay, here we have a schematic figure that depicting the embryology aorta, arches, and branches. Okay, 6 pairs of primitive aorta are developed between the ventral and dorsal aorta. Darker areas represent segments that normally involute. In the other diagram is the Radke diagram, which shows the 6-part embryology arch and 7 intersegmental arteries. Okay, which experience several changes by 8 weeks of fetal life. The dotted lines represent segments that normally involute, like the first and second branch. In the color represent how they finish. Okay, we're going to speak about it later on. This is already a serious schematic picture representing involution of aorta arch and their final age. Okay, it's how begin and how the aorta ends and the final stage. Okay, and for understand anomaly, we have to remember how the normal left aorta arch is too. In this picture, we can see the color ray, the regression of the distal right fourth arch. Because the normal left aorta arch results from regression of distal fourth arch from the right ductus arteriosus to the distal dorsal aorta. They remain in proximal aspect of the right fourth arch from the proximal portion of the right subclavian artery, and the left fourth arch from the final aortic arch. And this is the schematic from this final aortic arch. Okay, some definitions are important for this class. For example, anatomical variations, they are alteration of habitual disposition of the vessels, no pathological. Anomalies, they are resolved from abdominal persist and or regression of branches, and totipotential arch can be pathological. And vascular ring, then a third that refer the encircle in the trachea and the esophagus caused by the abnormal embryonic development of the aortic arch. Okay, let's begin with variants of the aortic arch. Bovine arch is the most common variant of the aortic arch, 8 to 25%, and occurs when the brachiocephalic artery are on common origin with the left common carotid arteries. In this imagine, we can see how the common carotid, left carotid have a common origin from the left brachiocephalic artery. The other one is left aortic arch with aberrant right subclavian artery. The most common variation of aortic arch with prevalence of 0.5 to 2%. Result from regression of the right arch, including the right ductus arteriosus. The distal right dorsal aorta, radiant and the right forearch becomes the proximal right subclavian artery, forming the retroesophageal portion. Okay, in gray, in this diagram, we can see the ductus arteriosus portion regression on the right forearch. How it's make the left aortic arch with aberrant subclavian artery. Okay, this anomaly is usually isolated but can be uncommonly associated with other congenital anomalies. It's usually asymptomatic. Approximately 10% of adults have symptoms of dysphagia, which is termed dysphagia luxuria. In this CT, we can see the aberrant right subclavian artery with the retroesophageal portion. So in the other one is the same, aberrant right subclavian artery passing posterior to the esophagus. Other kind of presentation is left aortic arch with diverticulum of KOMMERELL. When the right aberrant subclavian arteries arise from the opposition, it's called diverticulum of KOMMERELL, forming a loose vascular rim. The KOMMERELL diverticulum it remains of dorsal aortic arch and persists of the right sixth arch component from the right side ductus arteriosus. This diverticulum is more common on left aberrant subclavian artery on right side arch. This volume rendering will show aberrant right subclavian with the diverticulum of KOMMERELL from the right subclavian artery. Okay, and now we are going to speak about the right side aortic arch, and it consists in three variants, which we will see in each case. Right aortic arch with aberrant left subclavian artery arising from retroesophageal diverticulum is the most common variation of right aortic arch and the second most common cause of vascular ring after double aortic arch. This anomaly results from regression of the left forearch between the left common carotid and the left subclavian artery, usually with persistence of the left sixth arch. A portion of the left dorsal aorta typically persists as a retroesophageal diverticulum, giving rise to the aberrant subclavian artery. As you can see, this axial CT is an example where the right aortic arch is crossing posterior to the trachea and the esophagus. And this is a diagram that showed us the same. Okay. Right aortic arch with mirror imaging branching, the regression of the left dorsal aorta distal to the region of the 7th intersegmental artery makes the left fourth arch the proximal subclavian artery, rating and becoming the definite aortic arch. It's the second most common form of right side arch, and it's strongly associated with congenital heart disease in 98% of cases. Most commonly, tetralogy of Fallot and truncus arteriosus. Vascular rings not typical but possible. And this is a volume rendering that showed us a right aortic arch with mirror imaging. Okay. Right aortic arch with circumflex aorta. A circumflex aorta descends on the left. To do so, the distal aortic arch travels from the right to the left, posterior to the esophagus before turning downward. A left ligamentum arteriosus arises posteriorly from the diverticulum of Kommerell and connects the pulmonary artery to the descending aorta, forming a vascular ring. The aberrant left subclavian artery frequently arises from the aortic diverticulum with stenosis at the origins. The left aortic arch with circumflex aorta is analogous to the right aortic arch with circumflex aorta. To explain better, we have a coronal CT and a volume rendering that shows the arch crossing posterior to the trachea and to the esophagus, and we can see the left aberrant subclavian, left aberrant subclavian arising from a diverticulum of Kommerell. And the other image is a frontal esophagus, shows a large right indentation of the esophagus corresponding with the right aortic arch in this part. Okay. Other anomaly is the double aortic arch. Embryologically, the persistence of both the right and the left for aortic arch and distal dorsal aortic segments result from the double aortic arch, which each arch given rise to the ipsilateral separate carotid and subclavian arteries. Okay, in this diagram we can see how each branch, each arch give each branch. Is the most common cause of symptomatic vascular ring, as the trachea and esophagus are completely encircled and may be compressed by two arches. Clinical manifestations are wheezing and stridor exacerbated by crying, tachypnea and cyanosis, and dysphagia. The double aortic arch in radiographic findings, we can see bilateral paratracheal nodular opacities and distal tracheal indentation too. And we have a frontal and lateral view shows the esophagogram that show the indentation bilateral for the double aortic arch, and this is an indentation posterior from the trachea. Okay, and this CT shows the vascular ring producing a compression of the trachea and esophagus too. Okay, and different projections. In persistent fifth aortic arch, a primitive fifth arch may persist located below the fourth arch. This normally is usually associated with intracardiac malformation, frequently mistaken for a ductus arteriosus. A persistent five arch can do a systemic connection or systemic pulmonary connection. And in blue arrow signal, the person's fifth aortic arch is close relation with the left fourth arch and the left pulmonary artery. And the volume rendering is shown in two.
As Frank already said, which one do you think is going to be the consequence? As Franklin already said, which one do you think is going to be the consequence of a persistent fifth arch going to the pulmonary system? What do you think is going to happen, or how do you think it's going to behave like? He already said it. Second-year resident sophomores. What do you think? How is it going to behave, or what is going to seem immune?
The most common symptom or sign will be pulmonary hypertension due to the recirculating or the high volume that will be in the lungs.
And what other most more common pathology causes that? The circulation or the overload of the the pulmonary
persistence of the ductus arteriosus.
PDA. As how he already said, the PDA, it is often mistaken as a PDA, so that's something you have to remember. Always check the connections every time you see a baby with these small formations. Go ahead.
With this variant, we finish the first part, and the second part are the anomaly of the aortic arch. Okay, cervical aortic arch characterized by an aortic arch extended abnormally high in the neck, occurring more commonly on the right. And clinical manifestation is a pulsatile mass may be present in the supraclavicular region. As you can see in this CT, reformation shows high aortic arch with a peaks above level of manubrium and T3 and T4. The interrupted aortic arch is relatively rare congenital anomaly with prevalence of approximately 2 per 100,000 live births. It's characterized by complete anatomical discontinuity between the ascending and descending aorta. This separation may be complete or connected by a remnant fibrous band. The descending aorta is the most often through a PDA. Typically chokes on severe heart failure in the first 2 weeks of life. Has been classified into 3 types based on the size of aortic interruption and relation to each vessels. In any of the 3 types, the right subclavian artery may arise normally or abnormally. Okay, the type A.
Return to the last one. Just remember that congenital heart disease or big vessels heart disease can manifest either as shock or heart failure. And what was the other what is the other clinical feature that you have always to ask? It's more common. Usually, clinically, the babies, the newborns, can be divided into 2 big clinical presentations. Clinical. One is Edgar.
Cyanotic and not cyanotic disease.
And the not cyanotic, you have to be careful if they manifest as shock or severe heart failure. So you have to remember clinically those things when you're doing your boards and answering and seeing radiographs. Those are the things you have to ask. Those are the 2 clinical contexts: the cyanotic and the non-cyanotic. And the non-cyanotic usually are going to have this.
Okay. Type A. The arch interruption occurred distal to the origin of the left subclavian artery. This anomaly is believed to result from abnormal regression of left forearch segment late in development. After the left subclavian artery has ascended to its normal position, is the second commonest type of interrupted aortic arch. And the graphic depicts normal oxygenated blood arising from the aorta to the cervical region. Okay, and after the interruption, in purple, the descending aorta shows blood arising from the PDA. Okay. It's very interesting how here in this volume rendering there is not continuity of the left subclavian artery after the left subclavian artery, and in the CT, the same patient, the ductus arteriosus, the parent ductus arteriosus is the one shared given the blood flow and the descending aorta.
Just remember this lack of continuity. Those are the things you have to look when you see one of these anomalies. This lack of continuity.
Okay. Type B, The arch interruption occurs between the region of the left common carotid and left subclavian artery. This anomaly is believed to result from abnormal regression of the left fourth arch segment early in development, before cephalic migration of left subclavian artery. This is the most common form. Graphic depicts normal oxygenated arising from the aorta and the cervical region, the interruption, and how the PDA is charging the descending aorta, including the left subclavian artery. In this study of a patient with the George syndrome, as the same it's the same mechanism explained earlier here. The left subclavian is charged from the PDA. And the volume rendering is talking about the same. Type C, the arch interruption occurs between the region of the brachiocephalic and left common carotid arteries. This anomaly is believed to result from abnormal regression of the ventral portion and the left third and fourth arches. Type C is by far the least common form of interrupted aortic arch. And the diagram shows how the interruption is before the left common carotid artery. And the PDA is charting all this segment. Other anomaly is the parent ductus arteriosus. Parent ductus arteriosus is a vascular structure that normally connects the proximal descending aorta with the proximal left pulmonary artery. During fetal life, the ductus arteriosus allows shutting the blood away from the lungs. In full-term newborns, the ductus arteriosus typically close functionally 18 to 24 months. After birth, anatomically is 1 month. If it remains permeable 3 months after birth, it's considered a PDA. This condition is found in 1 of 2,000 children born at full term and occur for 5 to 10% of all congenital heart disease. It is most frequently in female to male ratio 2:1. Its prevalence is higher in premature babies, reflecting the failure of immature ductus arteriosus to close. PDA has been associated with maternal rubella and several chromosomal abnormalities. Diagnosis of PDA relies on the ability to demonstrate a patent connection between the aorta and the pulmonary artery with evident flow. Detailed description of ductus is important before attempting percutaneous closure of the PDA and during selection of closure material. Also, CT can demonstrate complications as cardiomegaly, pulmonary artery hypertension, and Einstein-Meyer syndrome.
This is a question for the juniors, the third years. Where are you usually going to search for a PDA? At what segments of the aorta that he already mentioned, where are you going to search for it?
Distal to the left subclavian artery.
Listen to the left. Usually in the adults, the ligament is 1 centimeter away from the origin of the left subclavian artery. That's at the the region of the isthmus. Sorry, that's where you're going to search for it. And usually, where does it go from the if it were present? And he already said to the pulmonary artery, but usually it's more commonly to find it what branch?
To the left one.
To the left one. Usually, you have to be very careful to see if it goes to the proximal part of the left, or a little bit more away from its origin, because it is sometimes that's something that you have to report in to the interventional doctors, the cardiologist who refer the patient.
Okay, we have the Krichenko angiography classification that divides in A to E. Okay, type A is a conical, is the most common type, and it's characterized by ampulla at the aortic end. Type B, window, is a ductus that narrow in aortic end. Type C, tubular, is a ductus with not narrowing or constrictions. Type D, complex, is a ductus with multiple constrictions. And type E, elongated, is a ductus with bizarre configuration with constriction away from the pulmonary artery end. The indication for closing PDA depends on patient age and the size of the ductus. There are different treatment options. This classification is usually in selecting the type of closure and the correct device. For that, it's important to know that. Aortic hypoplasia is typing of the distal aortic arch, and it moves after the first 3 months of life. The proximal arch segment is divided as hypoplastic when the external diameter is less than 60%, and that the ascending aorta. The corresponding limit of hypoplastic in the distal arch is 50%, and for the isthmus, its limit is 40%, where we are going to do the measure. The term tubular hypoplasia refers to combination of abnormal small diameter and increased length greater than 5 millimeters in the infants between the segment of the aortic arch. It can be isolated finding, but is frequently associated with other forms of obstruction or restriction to the aortic flow, most commonly aortic coarctation. Other associated congenital heart anomalies include atrial septal defect, ventricular septal defect, and patent ductus arteriosus. In a candid cone view, the descending aorta shows both the hypoplastic, the coarctation, and the collateral vessels. Okay, aortic coarctation involves aortic narrowing in the region of the ligamentum arteriosus, just distal to the left subclavian artery. It represents 7% of congenital heart disease, and it has male predominance. Aortic coarctation radiography is inferior rib notching or Ruslet sign, and figure 3 sign up the 50% of case, and mediastin widening. Okay, and in esophagogram we can see reverse figure 3 sign. Aortic coarctation, juxtaductal aortic narrowing and multiple collateral vessels. Is divided in postductal and preductal. It's about the subclavian artery. If distal left to the left subclavian is postductal, and above left subclavian artery is preductal. And the imaging is showing us the findings. Pseudocoarctation It's a rare anomaly characterized by kinking and buckling of the descending aorta at level of ligamentum arterioso. Unlike with true aortic coarctation, there is no significant hemodynamic obstruction of pressure gradient across the lesion, less than 25, and therefore no collateral vessel formation. Is the difference about a true coarctation artery. And there are, in this radiographic shows the buckling and the elongated aorta, but not a real coarctation. Is usually asymptomatic and is generally considered to be a benign entity that doesn't require surgical intervention. However, treatment may be required in symptomatic patients and those with associated aneurysm formation.
Return a little bit. What's the clinical difference of presentation between pseudocoarctation and coarctation related to age? I don't know if. Okay.
So the coarctation is usually asymptomatic.
Okay.
So I guess it's more common in adult patients.
What is it in here? What is this? An atheromatous plaque. So as you say, Lorena, is usually in older patients. You can see it whether, and actually, as the patient is older, it gives time, if you can see it, to the formation of the aneurysm formation. Number two, return to the rendering, volume rendering. What is lacking in here compared to the coarctation?
The collateral vessels.
Collateral circulations. In here, there is, and the pseudocoarctation is not going to have collateral circulation. And as Aldrio already said, it's usually asymptomatic, most asymptomatic as a incidental finding, or due to the mass effect of the aorta, but not related to the hemodynamic. And there are no hemodynamic changes in here. And return to the coarctation. And other thing for you to remember is that not every patient with coarctation are going to have collaterals. When the patient is younger, or usually in the neonates, there are not going to be collateral circulations, because let's just say it doesn't give time for the collaterals to develop. And if the patient develops, if the patient gets to the teenage years, or it's 8, 10 years old, what do you think that's going to be one of the systemic manifestations? You've already seen one in pets 1 or 2 months ago. It's something you have to, it's actually one of the indications. Well, yeah, symptoms. That give her the
Systemic hypertension due
Systemic
to the
hypertension.
low perfusion of the kidneys.
exactly, because there is not enough circulatory volume for the kidneys. It's going to manifest as hypertension. So in a young patient with non-apparent cause, a patient who's going to be usually thin, that can do lots of things, with normal development is going to present with hypertension. Usually, and I don't know how often is this other one feature, they can have also slow performance in sports because of the compromise to the circulatory delivery. Yes. Juanpi, you were going to say something else?
You can see a difference in the pulses and the superior
between the superior
limbs and the inferior limbs.
What's going to be the difference? Which
Well,
one is going to be increased or diminished?
Increasing the superior and decreasing the inferior.
Okay. And what else other things? And I don't know if Franklin already said it. Remember that the aorta is just not the arch or the ascending or descending. You have to check always the valve if it's possible. Most of the study are not going to be. Most of the study are going to be non-gated. So if you can see the morphology of the valve and it has a very frank anomaly, report it. If it's not possible to report it, you say that it's not valorable. It's something that that can be done. Usually the echocardiographies, the cardiopediatricians is going to tell you that they only have doubts in here. It's going to be very weird for a child to be that they have doubts in the intracardiac structures, although it is possible.
In conclusion, the aspect of aortic disease is broad and varied. They result from aberrant development of one or more components of the embryonic arch system. Non-invasive imaging with CT and MRI angiography allows for complete evaluation of the aortic arch and branch vessels in relation to surrounding structures, including the airway and the esophagus. Familiarity with spectrum and imaging appearance of aortic arch variants and anomaly is essential for accurate diagnosis and classification and guide treatment. Okay, thanks.